Good morning, everyone. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Shahnawaz. Dr. Shahnawaz is double board certified in internal medicine and rheumatology. She completed her residency in internal medicine in 2016 and a fellowship in rheumatology in 2018 at SUNY Upstate Medical University, Syracuse, New York. As assistant professor in internal medicine, Dr. Shahnawaz was teaching medical students and fellows before she moved to Texas. She now has her practice in Plano, Texas, and specializes in diagnosing and treating a myriad of rheumatologic disorders, including but not limited to lupus, rheumatoid arthritis, inflammatory muscle disease, gout, and PMR in adults of all ages. Dr. Shahnawaz has a passion for helping patients struggling with arthritis and inflammatory problems to provide them with the best care that fits their needs. It is my honor to introduce Dr. Shahnawaz and request to begin today's session. Thank you.
Hi guys, I'm so glad to be talking to you about this. As you know, when we say arthritis, we're mostly thinking about joint involvement only, but honestly, rheumatoid arthritis is much more than that, as I'll go into more detail. So that's why I picked this topic, because it's not only one of the most common inflammatory arthritides, it has also got some extra-articular manifestations. So arthritis, the word itself is from two words, arthro meaning joint, and itis, as you know, stands for inflammation. So RA is a chronic systemic inflammatory disorder that is autoimmune, which means that basically your own immune system can get a little confused and sometimes start to attack your own joints, tendons, bones, and resulting in inflammation and destruction of these tissues. I'm going to just move this window on the right a little bit. And so basically, it will occur in approximately up to 1% of the population and is twice as common in women compared to men. Here's just a cross-section of a normal knee joint from the lateral aspect. As you can see, there's the patella right here, and this is the leg bone, the upper leg. So this would be the femur, and down here is the tibia. The normal joint would have this kind of cartilage in between to give some shock absorption. This allows for friction-free movement, but this does not have any nerve endings. This, however, behind the patella is where the synovial membrane is, which secretes the synovial fluid. This fluid will nourish the cartilage and cushion the bone. And when there's pathology or disease happening, it would look something like this. So as you can see, the cartilage is getting eroded a little bit. There's pitting, and there's inflammation here over the synovial membrane right here. And the fluid can actually increase in size. You can see it's a little bit wider here. So when the skin tenses, the fluid is more, the bone is pushed. That's the mechanism of how one would feel pain and pressure. So this is an inflamed knee joint. It can happen anytime between 30 and up to 60 years, but can happen in even 70-year-olds. Sometimes I do see a late onset. It could be because either they were just presenting late or just the onset was late. But this would be the common age group demographic. And like I said, it happens more commonly in females, twice as more. The pattern of joint involvement could be either classic RA, which is most common, where you would have the typical small joint symmetric involvement, or it could be palindromic rheumatism, which is more of an episodic, or monoarticular, which is not that common, but it could involve one joint at a time. Another hallmark finding is morning stiffness. So joints would characteristically be more stiff for greater than an hour in the morning, and it gets better with physical activity. And small joints of the hand and feet are typically involved. Okay, so from the clinical manifestations, I'll go into articular involvement, which is the joint involvement a little bit, and then go over some extra-articular, which means outside of the joint. So as you can see, there can be pain and swelling affected, joints can be affected by pain and swelling. So the patient would complain because if the joint is swollen, they would complain that when we move, we feel that it's very tender, and then stiffness in the morning again is hallmark. And as you can see, the smaller joints in both sides of the hands and feet, the medium joints, some large joints, but not large joints is not as common, but it will spare the axial skeleton and the hip joints for the most part. You can see SI joints can be involved, but it's not that common. And you can see the vertebrae are not typically involved. So 90% of the time you'd have metacarpophalangeal joints or proximal interphalangeal joint involvement of the hands and the MTP joints of the feet. Knees and ankles and wrists can be involved up to 80% of the time, shoulders up to 60%, elbows 50%, and the acromioclavicular joint, SC joints, TM joints 30% of the time. Instability at the cervical spine can lead to impingement of the spinal cord. There's typically not any involvement of the distal interphalangeal joints, which would be the ones right here. So this joint would be the DIP joint. These are typically not involved in RA, and the SI joint, it would be rare for the SI joint to be involved. Here's a picture of the proximal interphalangeal joint, being involved. So there's swelling, as you can see, on the second and third. Right here, there's some over here as well, and the MCPs are also swollen. You can see a little bit of deformity too. This one shows the ulnar deviation. The MCPs are swollen, and the left wrist is also swollen a little bit. So the first one right here is the boutonniere deformity. So you would have this type of flexion deformity right at the PIP, and the DIP is a little bit extended. The swan neck deformity is a little bit opposite. So this part right here is the PIP, and this is overextended, and the DIP is flexed. Similar, you can see almost both of those in this picture. So among the extra-articular manifestations, I'd like to mention that they happen in almost 30 to 40% of patients with RA, and they might actually be the presenting complaint. So rheumatoid arthritis is usually presenting with joint involvement, but sometimes it can just present with lung manifestations or eye manifestations, so outside of the joint. And the patients that are most likely to get extra-articular manifestations are the ones that have very high titer of rheumatoid factor, and the CCP antibody is extremely high. Some of these patients have presence of anti-nuclear antibody. These patients also have a shared epitope, the HLA-DRB1. They are male in gender, early onset disability, and history of smoking has tons of data linking it to extra-articular manifestations and rheumatoid arthritis in general. Constitutional symptoms are most common, so fatigue, malaise, just feeling run down when the disease is active or when the disease sets in. Rheumatoid nodules can be seen in 30% of the time. Hematologic, so on the CBC, you'd see a normochromic, normocytic anemia. The white cell count could be high or low, and the platelet count could be elevated. So it would be like a reactive thrombocytosis. There's one syndrome to keep in mind for patients with a chronic nodular rheumatoid arthritis known as the Felty syndrome, where you'd have a large spleen and the neutrophil count would be going low on this differential. So that is a complication of RA where there's splenomegaly and needs to be considered if you see the neutrophil count going low in somebody who is chronic rheumatoid nodular. Respiratory could be pleural effusion. So the lung has a lining outside of it, as you know, called a pleura that has pleural fluid inside that can actually increase, and there can be a lot of fluid built up. And we can test it there's a way to remove the fluid and test it for cell count and other, and there's a specific way to find out if it's inflammatory versus malignant. So Pleural effusion is a complication, pneumonitis, pleuropulmonary nodules, and interstitial lung disease. Among cardiovascular complications, you can have pericarditis. So the pericardial lining can be inflamed, presenting as sharp chest pain when you take a deep breath in, pleurisy, and it's respiratory, and pericarditis, positional chest pain, pericardial effusion, cardiomyopathy. Rheumatoid vasculitis is a very severe complications. It will mostly present with a foot drop or a wrist drop. So patient will tell you that I'm not able to lift my wrist or I'm dragging my foot. So mononeuropathy, cutaneous ulceration, you could have skin ulceration, digital gangrene or visceral infarctions, any of the organs could get infarcted. CNS involvement would have peripheral neuropathy, cord compression from the AA, the atlantoaxial joint right here in the neck, mid-cervical spine subluxation, entrapment neuropathies like carpal tunnel syndrome. And then eye complications would be various inflammatory eye diseases like scleritis, episcleritis, or just dry eye, dry mouth syndrome. So keratoconjunctivitis sicca in the eye. So as you can see, there's some rheumatoid nodules in both these pictures. The first one. Now, what is a rheumatoid nodule? These are small subcutaneous nodules present at the extensor surfaces of hand, wrist, elbow, and back in rheumatoid arthritis patients. They're a very characteristic feature of RA, and they can be a marker of disease activity. So if you have a lot of disease burden and the RA is very, very active, you'd expect to see this more so. And they can be present even if other features of RA are absent. Lab investigations in RA typically will include getting acute phase reactants, which include complement levels, and CBC with differential, the inflammatory markers like erythrocyte sedimentation rate, C-reactive protein, rheumatoid factor levels, and CCP antibody levels. Antibodies that recognize Fc portion of IgG is what a rheumatoid factor is basically doing. So it can be IgM, IgG, or IgA. 85% of patients with rheumatoid arthritis over the first 2 years become rheumatoid factor positive. So there is a way you can still diagnose it even if they're rheumatoid factor negative. I'll come to that later, where even if their rheumatoid factor levels are not present, you can repeat it every 4 to 6 months till they become seropositive, but you can make the diagnosis of seronegative. So every 6 months, if you check it, they may become positive up to in 24-month period or 2 years. So there is a prognostic value in these markers. Patients that have very high titer of rheumatoid factor in general tend to have poor prognosis. They have more extra-articular manifestation, more complications, more deformity as well. So this is an important slide to keep in mind because rheumatoid factor elevations are not happening only in rheumatoid arthritis. You can have other conditions where rheumatoid factor can be seen positive. It may be a false positive, but some of these are also autoimmune. For example, Sjogren's syndrome, the dry eyes, dry mouth syndrome, you can see mild elevation of rheumatoid factor. Also because Sjogren's syndrome can be secondary Sjogren's from rheumatoid. Vasculitis such as PAN, sarcoidosis, lupus, cryoglobulinemia, chronic liver disease. And false positives can be seen in infections. So if someone has TB, bacterial endocarditis, viral hepatitis, infectious mononucleosis, leprosy, syphilis, leishmaniasis, so these can cause a mild elevation of rheumatoid factor, which is not from rheumatoid arthritis, but just there because of that mechanism over here, that the antibodies right there to the Fc portion. Malignancies can also cause the false elevation, and people in the older age bracket can also have false positive rheumatoid factor elevation mildly. 5% of women above the age of 60 have it, but so do men. The anti-CCP antibody is an IgG against synovial membrane peptides and causes damage by inflammation. It is very sensitive, but it's more specific than it is sensitive. So if you see this positive, it is very, very characteristic of rheumatoid arthritis. But you can see a CCP antibody in any inflammatory arthritis, and the presence of it just means that you can expect a more erosive, more deforming arthritis in that particular diagnosis. So 1 in 6 lupus patients will have a CCP antibody, but this is very characteristic for rheumatoid. This one also has a diagnostic and prognostic value. You can expect it to be a little bit more deforming. Acute phase reactants, I mentioned a few of them. So you might see mild elevations of complement level C3, C4, ceruloplasmin. There's moderate elevation of haptoglobin, and the ESR, of course, is well known, and you'd see that being elevated. And marked elevations of CRP can be seen, and the serum amyloid A protein. The albumin level can go down, and so can the transferrin level. So again, some APRs, platelet counts can be elevated. White cell count can go high in RA, and ANA can be seen in 30 to 40% of the population. If you do an arthrocentesis, as in remove fluid from, let's say, the new joint, you can actually send it to the lab and see what kind of cells we're seeing, and it's mostly inflammatory. You'd see more white cells, and that would give you an indication that the fluid is inflammatory. There's a table we can look at and see if it's going over a certain number, then it's most likely to be inflammatory. Among radiographic features, these are very useful, because if you see a radiograph and you see periarticular osteopenia, it is a kind of a clue that there's inflammation going on. Another one is uniform symmetric joint space narrowing, marginal subchondral erosions, joint subluxation, joint destruction, and then collapse. You can detect early soft tissue lesions via ultrasound, but MRI has the greatest sensitivity to detect synovitis and marrow changes. So X-ray, ultrasound, MRI, they're all great, but X-ray is great for bony changes. Ultrasound can look at soft tissues. No, it's just a quick thing you can do in the office, and MRI to get, insurance approval and everything, but it does show marrow changes, bone marrow edema. Here's a radiograph. In the first one, this one, you can see there's a little bit of blackish, so it's not radio opaque like this. You can see that the X-ray images are kind of penetrating more this area. It's because the bone is thin, it's osteopenic. This is called periarticular osteopenia. Right here, you can see there's joint space narrowing, and over here, it looks almost like someone's taken a bite out of it. So this is an erosion. This is what a hand joint erosion, a marginal erosion would look like. I don't know if you can appreciate there's a slight bit of subluxation too. It looks like almost the joint is falling over. I'll show you in the next slide too. Right there, you see at the first MTP joint, it's almost like it's falling over to the lateral. And you can see severe joint space narrowing right here, some erosions in between right here. Over here too, you can see joint destruction, subluxation, and narrowing all over with erosions. This is somebody's neck, so skull. This is the atlantoaxial joint right here, and you can see some changes, RA type changes right there. They can be in the AA joint, there can be a superior migration of the dents, and you can have subluxation at the AA joint as well in RA. It's a common complication, something to be aware of. Patients do complain of neck pain in RA. So this is a busy slide, but this is the most updated 2010 diagnostic classification criteria for RA by the American College of Rheumatology and EULAR. And this is just to tell you that you need a total to make that diagnosis for research purposes and for documentation. You need a total of 6 points out of all these, equal to or greater than 6 points. So as you can see, if you have one large joint, you don't get that much weightage. If you have 10 small joints, you get 5 points. So you need 6 total to make a diagnosis. So if you have more than 10 small joints you get 5 points. And if the symptom duration is more than 6 weeks, you get 1 point. So that would be enough to make that diagnosis, even if the serology is negative. But as I said, you can keep checking up to 2 years. The rheumatoid factor may get positive. If your suspicions are, you can keep checking. And then, you know how sometimes in clinical practice, other physicians and specialties wonder, why do rheumatologists check the CRP and ESR? Because so many conditions can lead to elevated CRP and ESR. But the thing is, it is given weightage in the ESR classification. So if you find an elevated ESR or CRP, you do get 1 point right here. So it can help with ruling in RA. So just going to go over management real quick. The goals of therapy are focused on pain relief, preventing damage. So you want to control this early so there's less deformity, less damage and disability, and need to educate the patient about the disease. Physical therapy for stretching and range of motion can help, because when these patients have a ton of joint pain, they try not to move those joints, and they can have like a frozen shoulder and other problems. So stretching and range of motion exercises are extremely important to kind of preserve that. Occupational therapy can be very helpful for splints and adaptive devices. For example, if you have a certain deformity, you're not able to put on your shoes or do certain things that you were able to prior to having that type of hand or foot deformity. They have certain devices that can actually help patients accomplish that. And treatment should be aggressive, and it should be early, and it has to be customized to the patient, their needs, their lifestyle and everything. But I will go over some modalities that are preferable over others. So NSAIDs play a big role, steroids play a big role, but they're not good long-term treatment. The mainstay for chronic long-term treatment for RA is DMARDs, stands for disease-modifying anti-rheumatic drugs, and immunosuppressive therapy such as biologic therapies and surgery. Among NSAIDs, they can reduce pain and swelling by inhibiting cyclooxygenase. They do not alter the course of the disease, so they are not DMARDs, they're not disease modifying. Chronic use should be minimized, and most common side effect is, heartburn and gastrointestinal ulcers. Chronic kidney disease can also occur if you take it for way too long. These are the ibuprofens, the naproxen, etc. Corticosteroids in RA have a big role as well, but again, not great for long-term use. They can be used for treatment flares and extra-articular manifestations like vasculitis and interstitial lung disease, for pulsing, or for high-dose steroids for like organ involvement, systemic involvement, severe complications. Or they can be used as bridge therapy. So the DMARDs don't start working right away when you start someone on it, and you'd need maybe 6 weeks or 8 weeks, the lowest possible dose for the shortest duration possible, as bridge therapy till the DMARDs can kick in. Sometimes in pregnancy, when certain DMARDs cannot be given to patients, so the corticosteroids can be a lifesaver at that time because they're safe during pregnancy. So disease modifying are actually that alter the disease course. They should be used as soon as the diagnosis is made, and appearance of benefit can be delayed for weeks or months. NSAIDs can be continued with them until true remission is achieved. Induction of true remission is unusual. So commonly used DMARDs are methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide. And less commonly used are azathioprine, cyclosporin, cyclophosphamide, chloroquine. Hydroxychloroquine is a common one. The advantage is it does not suppress the immune system. The dosing is weight-based, and the side effects to watch out for would be skin pigmentation. There's an eye side effect, so you need an eye exam. And then methotrexate, the dose can vary between 7.5 milligrams to 25 milligrams once a week. So here's a huge advantage, that it only needs to be taken once a week, and then you have the effects for the rest of the week. And there's so much room to titrate the dose. You can So 7.5 milligrams to, it could be, it's in increments of 2.5, so you do 10 or 12.5 or 15. There's so much room to play with the dose. Everybody's different. You can actually customize to a particular patient. The great thing about methotrexate over hydroxychloroquine is that it works much faster. So you'd see some benefit at 4 weeks to 8 weeks would be, it would be steady state at that time. But hydroxychloroquine can take up to 3 months to start working. Sulfasalazine, also a good one, 2 grams a day. It can, however, as a side effect, cause bone marrow suppression and can reduce sperm count. The blood counts need to be repeated every 6 to 8 weeks with the liver function tests for all of them except for the hydroxychloroquine that only needs the eye exam. And leflunomide is another great one. It only comes in 2 doses, a 10 milligram tablet and a 20 milligram. And nausea, diarrhea, alopecia, hepatotoxicity are stuff to watch out for. And on this one as well, we would do the LFTs 6 to 8 weeks. You can stretch it out to up to 12 weeks, but it also has a quicker onset of action than hydroxychloroquine. When do we start DMARDs? They're indicated in all patients with RA who continue to have active disease. A small percentage of patients may go in spontaneous remission. The vast majority, however, will need DMARDs, and many rheumatologists would start them from day 1. There are no strict guidelines about which DMARDs should be started first, but taking into account patient tolerance and cost and ease of once weekly, methotrexate is the DMARD choice and most widely prescribed. It has a rapid onset of action as well, and monotherapy works really, really well for a lesser disease burden and if there's less markers of poor prognosis. So single DMARD therapy in conjunction with NSAIDs is often modestly effective. Combination therapy has an inherent appeal. DMARD combination is especially effective if it includes methotrexate as the anchor drug. There is a combination with the sulfasalazine, the methotrexate, and hydroxychloroquine. The 3 together are known as the triple therapy, and they are non-inferior to Humira, which is a TNF inhibitor with Biologic, which I'll come to. Just a few limitations of conventional DMARDs. The onset of action takes several months. The remission induced in many cases is partial. There may be substantial toxicity, which requires careful monitoring, so you need to do those labs frequently. The DMARDs have a tendency to lose effectiveness with time, and these drawbacks have made researchers look for alternative treatment strategies for RA, which are the biologics. So biologics in RA include, they target cytokines such as TNF-alpha, interleukin-1, interleukin 10, etc. are the key mediators of immune function in RA, and these are the major targets. Of the various cytokines, TNF-alpha has attracted maximum attention. Various biologics approved in RA are the TNF inhibitors, so these will block TNF-alpha. Infliximab is an infusion. Etanercept is an injection at home. Adalimumab is also an injection. Interleukin-1 receptor antagonist like anakinra has a role. Interleukin-6 receptor antagonist tocilizumab has a role. Anti-CD20 antibody rituximab, and T-cell co-stimulatory inhibitor abatacept, JAK kinase inhibitors like tofacitinib. I was going to say the brand name, but tofacitinib is great. So here's just a table. I'll just go through it real quick. So if you see disease activity is low, you can get away with just DMARD monotherapy. If disease activity is high, come down here. Features of poor prognosis, like very high titer rheumatoid factor or CCP antibody or radiographic progression, or erosions are already present, swelling's not going down. So with presence of those features of poor prognosis, you would target to start an anti-TNF with or without methotrexate, or a combination therapy. The double therapy would be methotrexate with hydroxychloroquine, or triple therapy, which would be sulfasalazine, methotrexate, and hydroxychloroquine, all 3 together. Without features of poor prognosis, but high disease activity, you could do DMARD monotherapy or do the double therapy. Okay, if the disease activity was moderate, with features of poor prognosis. Then you would do combination DMARD therapy, double or triple. But if there were no features of poor prognosis, you could get away with just doing DMARD monotherapy. So how would you monitor treatment? The disease activity is assessed by several parameters. So if the duration of morning stiffness has gone down, the number of tender joints, like literally you could count how many tender joints are present, how many swollen joints are present. You would have your own count and the patient would tell you these joints are tender, they would have their own count. Keeping that in mind, if those numbers are going down, the observer global assessment would be us, the patient global assessment, visual analog scale for pain, health assessment questionnaire, levels of ESR for monitoring purposes. These can all be great parameters to kind of monitor disease activity. Patients on methotrexate, sulfasalazine, or leflunomide show clinical improvement in 6 to 8 weeks. Patients should be observed for 6 months before declaring a DMARD ineffective. Once remission is achieved, maintenance dose for long periods is recommended. Relapse occurs in 3 to 5 months, 1 to 2 months in case of methotrexate, if drug is discontinued in most instances. DMARDs are discontinued by patients because of toxicity or secondary failure, and such patients have shifted over to different DMARD over 5 to 10 years. Disease flare may require escalation of DMARD dose with short course of steroids. So just at the end, I want to go over some surgical approaches when the disease burden is high and we're not able to control with just medications. These surgical approaches can help as an adjunct. So synovectomy is ordinarily not recommended for patients with rheumatoid arthritis, primarily because relief is only transient. However, an exception is synovectomy of the wrist, which is recommended if intense synovitis is present despite medical treatment over 6 to 12 months. Persistent synovitis involving the dorsal compartments of the wrist can lead to extensor tendon sheath rupture, resulting in severe disability of hand function. Total joint arthropathies, particularly of the knee, hip, arthroplasties, particularly of the knee, hip, wrist, and elbow, are highly successful, which is another way of saying joint replacement, total hip replacement, etc. And other operations include release of nerve entrapments, for example, carpal tunnel syndrome, arthroscopic procedures, knee arthroscopy, for example, and occasionally removal of a symptomatic rheumatoid nodule, because aesthetically there's disfiguration, etc. Thank you. Do you guys have any questions?
Thank you so much, Dr. Shahnawaz. My name is Jocelyn. I'll be doing the Q&A session. I'm from Georgetown. That's the last place I graduated from with my master's in physiology and biophysics. So we're just gonna head into the Q&A session. So the first couple of questions are related to rheumatoid arthritis. So with the specific risk factors associated with RA, is there any way to prevent this, or do we know if there's more likely to develop this in the future?
So risk factors do include smoking is a big one. There can be a genetic predisposition, and there are markers such as some, the human leukocyte antigen HLA, DRB1 for extra-articular manifestations. These are common risk factors. How can you prevent it? First of all, if you're a smoker, it would really help to quit smoking. There's so many programs out there. You can seek help from your community, or you can reach out to your primary care physician. So many different methodologies out now for this, medications as well to help, come off of the cigarettes and that sort of a thing. And then also having like a dietary approach can also help to a modest extent, but it does help. Practically a lot more, because patients will tell me in the clinic that they do feel significant improvement when they go on a cleaner diet. So that can help. There's certain foods that have more antioxidant properties. Omega-3 fatty acids, I know I sound like a broken record. It's all over media and everything too, but Certain fish, for example, salmon can have benefit, or even supplements with omega-3s can help. But you just have to make sure you're buying from like a well-reputed place. And just certain fruits, for example, blueberries, they have antioxidant value. So that can be a very good addition to somebody's diet. Trying to avoid more inflammatory foods like refined sugar and carbohydrates that are not like whole. And for example, so just doing more whole foods.
Okay, thank you. And then also with prevention, as young adults now, it's just like exercising and stretching daily. Can that help with joint inflammation, or is it more on the dietary and lifestyle factors?
Definitely exercise can help. Our adipokines are very inflammatory. So the fat cells, adipocytes make adipokines extremely inflammatory. You can actually see CRP elevation if there's a ton of adipokines just from that, even if you don't have RA. So definitely exercise can help. And then again, as I was mentioning during the presentation as well, if there's a lot of inflammation, patients tend to keep their posture, not move that much. So that's where the role of physical therapy can be so great, where you're stretching out those joints and smaller and larger joints, so you don't develop complications of just not using that. And so stretching does help, exercise does help. So we usually recommend 30 minutes 3 times a week to start out with. And even those 30 minutes don't have to be done at the same time. You could break it up in 3 times a day. So 10 minutes, 3 times a day for maybe Monday, Wednesday, Friday. Once you do develop tolerance, as in you are able to do that more, then you challenge yourself with adding a 10-minute.
Okay, great. And then also for rheumatoid or positive rheumatoid factor, is there an etiology for it?
Say that again, there's a what?
Or an etiology for it, like where does it come from for positive rheumatoid factor when you diagnose?
It's an antibody, so your body is making it. Sometimes just all these risk factors, they're triggering its formation. So basically, if you have those risk factors and you have been exposed to certain toxins, certain genetic factors, toxins could be the ones that you're inhaling through smoking or just in the environment. I mean, there's so much pollution, etc. So if you are exposed to all of that, your body will get confused. Your immune system is making it on its own. So it's your own immune system thinking your cells are foreign and it needs to attack it because of all those toxins in your cells in your body. So it's your own immune system trying to attack and make those from the B cells. You make those antibodies, kind of.
Thank you for the explanation.
No, sorry about over-explaining and
it's
oversimplifying, but I hope that makes sense.
And this next question came from the live YouTube chat. It was just, is there any correlation between rheumatoid arthritis and coronary artery disease?
There's a huge relation. When I talk to my cardiology colleagues, they see so much atherosclerosis because we call it accelerated atherosclerosis in RA. If there's so much inflammation, you're going to have more plaque buildup in those big coronaries, and you can have a faster deposition and then higher complications because of the narrowing of the vessels. So definitely a huge risk factor, very, very high chance of cardiac complications and as part of the disease. But the treatment would be to treat the rheumatoid arthritis itself, reduce the disease burden. But peripheral vascular disease, just generally those arteries, those vessels have a lot more disease burden than someone who does not have rheumatoid.
And for the medications that you talked about, is there any medications that are essential for preventing joint deformities than just treating them?
Not really. They're disease modifying, so it's in the middle. So some of those medications do alter the course of the disease. Consider it like this: if you were not to get started, if someone was to take them, it would on a big scale improve the outcomes to such a great degree because they would modify or alter the disease course entirely. compared to somebody who wouldn't get them. So they are disease modifying. They don't essentially prevent, but in a way they do, because if you start them early, then the chances of developing those complications it's night and day. So if untreated, you would definitely get those deformities like the ones in the picture that I was showing.
Okay. And then there's another question that's, is there a possibility of taking a drug holiday with rheumatoid arthritis?
It's you can relapse if you come off of it completely, but there is if you talk to your rheumatologist, and it's also case by case, you could cut down on some of the doses if you are in remission and you've been in remission for 2 years. You could potentially cut down on some. You may not need to be on, let's say, rituximab your whole life, or cyclophosphamide. Those are just for like really, really bad complications. So if your regimen includes maybe 3 or 4 different DMARDs and medications, there is a chance that you are able to come off of the glucocorticoids entirely, which is the goal. Actually, we want everybody to come off of the prednisone as soon as possible because of the toxicity of it, and then come off of the NSAIDs, and then maybe reduce the dose of the methotrexate, because there's so much room to play with the dose with methotrexate. So yeah, definitely cut down on it. Come off of it completely. There's a very high chance of relapse. So it's kind of in a way preventative to stay on it.
Okay. And speaking of the NSAIDs, since they're contraindicated, what's the preferred alternative for them?
They're not entirely contraindicated. They can be a great adjunct. So once you are able to control the disease with DMARDs, I think that would be the best treatment. So hopefully you'd come off of the NSAIDs and the steroids, but there's no harm in taking here and there for as needed use. It's just not a long-term solution. DMARDs would be the best long-term solution. And controlling the risk factors like avoiding smoking, getting on a healthier diet, weight loss, exercise, stretching, occupational physical therapy.
This question came from Shadra in the chat, and he just asks, how do you differentiate between rheumatoid arthritis and osteoarthritis?
So everything that we were talking about today really is very, very typical for rheumatoid. You will not see high titer ESR, high titer rheumatoid factor, high levels of ESR, elevated CRP to that extent, CCP antibody in osteo. That would be the big thing. You would not see those hallmark markers in osteoarthritis. Osteoarthritis would only have the joint space narrowing and degenerated cartilage. It would not have the punched out erosions in the margins, the subluxations. Those are very typical for rheumatoid. Osteoarthritis would not have these extra-articular manifestations. It would not cause rheumatoid nodules. And yes, usually osteoarthritis would not improve with low-dose prednisone. So it's not, osteoarthritis would be a non-inflammatory mechanical type of arthritis, and rheumatoid arthritis is primarily inflammatory arthritis.
And next, we're just going to switch gears to ask a few questions about lupus and leukocytoclastic vasculitis. So what is the difference between leukocytoclastic vasculitis and systemic lupus? Clinically, they're very similar, but how do the biopsy results used to rule out the differentials?
Systemic lupus is a body-wide kind of disease. It doesn't have just vasculitis. Systemic lupus is diagnosed based on certain ACR criteria. The most recent ones that they outlined in 2019 was like a ANA titer greater than 80 and certain other, again, it was a point system, and you need to have a total of 10 points to make that diagnosis. The list will include pleurisy, low white cell count, everything has weightage, again, low thrombocyte levels, so any type of cytopenia, hemolysis and hemolytic anemia, that would be part of it. And then clinical findings such as Low-grade fevers are part of it, sores, canker sores inside the mouth or nose. And leukocytoclastic vasculitis is it's a histologic diagnosis. SLE is a clinical and laboratory criteria of a different thing. Leukocytoclastic vasculitis can be seen in SLE. It can be seen in other conditions. SLE itself is a completely discrete entity. It's completely separate, where the vasculitis can be part of SLE, but SLE is never part of the vasculitis.
And since it's a systemic, you said lupus was a systemic disease. What are the internal organs that it affects, and how does it affect it?
So you can have skin manifestations. If it's only in the skin, you would name it cutaneous lupus. And there's different variety of skin manifestations in lupus. Organs-wise, you can have kidney involvement, you can have brain involvement, you can have GI tract involvement, you can have joint involvement, eye involvement, lung involvement, basically heart involvement. Any system can get involved in lupus. It's system-wide, so it's systemic. When it's SLE, it could be anything. There are very helpful markers that can help predict which organ can get involved. For example, I'll just give you one example. If you have a double-stranded DNA that's positive, then chances of SLE going to the kidney is kind of high. So lupus nephritis would usually have some double-stranded DNA. So that would give you some kind of prediction as to what it's going to do. That's why that's the role of blood work as part of lupus.
And then also, can stress or psychological factors impact the severity of lupus or leukocytoclastic vasculitis symptoms?
Honestly, in practical, I have seen patients will tell me that. So they will say, I'm going through some stress and more physical activity, and just they seem to think that it does. So whether, things like that can do. So physiologic stress, some females will tell me that they will get a flare of either RA or lupus or another autoimmune disorder around their menstrual period. So I think that does have a role. And
I know in the presentation you said that female or women are affected more by rheumatoid arthritis compared to men. Is there a reason why, or is there any etiology for that one?
I think that's more, I think at a more molecular or cellular level, more at like a cytokine level type of, certain races are, certain genders are, certain age groups are. For all autoimmune diseases, certain diseases will happen in certain age groups. It's just at the molecular level, they just do that at a certain time in people's lives, or in a certain gender, you have more of certain cytokines. So I think that's probably why.
And then we have another question from the chat. It's asked, what is the difference between CRP, ESR, and RF markers? Does each one signify something separate in relation to rheumatoid arthritis?
So ESR and CRP are both inflammatory markers. Rheumatoid factor is an autoantibody. The ESR CRP can be seen in any inflammatory condition, but the mechanism of CRP elevation is something called interleukin-6. If you have high titer interleukin-6, you do make that CRP. So whatever the reason may be that you're having interleukin-6, we saw during the COVID-19 pandemic that a lot of those patients were having increased levels of CRP. So infections are a big driver of CRP because of high levels of interleukin-6. There's another pathology, the pathogenesis of which is again interleukin-6, called polymyalgia rheumatica, giant cell arteritis, rheumatoid arthritis. All the conditions that cause elevated interleukin-6 will lead to CRP elevation. ESR is the erythrocyte sedimentation rate. That is, they see how long or what's the rate in millimeters per hour of how the erythrocytes, which are the red cells, they stack up. Again, it can be very helpful in marking how much inflammation. So the rule of thumb is the higher these markers, the higher the inflammation. So both of them will tell you a measure of inflammation. ESR can be falsely seen elevated in certain conditions like older age, anemia, chronic kidney disease, but they can be seen. So you have to look at the whole picture. Do they have chronic kidney disease? Do they have longstanding anemia? Do they have joint swelling? So markers themselves aren't the true answer. You have to look at the whole human and see what they have, what they don't have, and then kind of make that's your clinical judgment. And then it comes with practice, and then you see all these various scenarios, and then you get used to this pattern recognition. And the third one you asked about was the rheumatoid factor. That's very hallmark for rheumatoid arthritis, but there are conditions that can lead to false elevations of rheumatoid factor. Your body can naturally make that over, let's say, over course of time because of those, like the list I was going through where you can have false elevations of rheumatoid factor. It may look like the rheumatoid factor is elevated, but it's not truly rheumatoid arthritis because they don't meet the 2010 ACR classification, and they have one of those other conditions on that list.
For that. And this other question is, since there's 4 stages in rheumatoid arthritis, how can you differentiate between them?
You mean the 3 types of presentation? So if you have more episodic, then that's called the palindromic, where you'd have episodes of various joint involvement, and then it would go away, and then it would come back. So more like a cyclical episodic kind, that's called a palindromic. Not very common. And then there's the monoarticular, where one joint would be involved at a time. Also not typical. The extremely typical classic RA would be differentiated by the bilateral symmetric joint swelling, primarily involving small joints of the hands and feet, sometimes moderate sized joints, so medium sized joints, and rarely large sized joints. Again, if you look at that table for the classification criteria, high weightage is given to smaller joints. So that would be the more typical. So if you see an episodic pattern, you would classify it as palindromic. You see one joint, monoarticular, polyarticular, or typical classic RA would be just this typical bilateral small joint primarily, and then some large joint or moderate sized joint involvement.
And from the the radiographic images that you've shown, were they all classic images of rheumatoid arthritis, or some of them palindromic or the other?
So the radiographic is true for all types of rheumatoid. So the radiographs can be seen. So the 3 presentations we're talking about is based more on frequency and presentation. The radiographs would look the same. So the pictures of the X-rays, whenever you have joint swelling, they would look like that as part of the rheumatoid picture. I hope that's making sense, in the sense you would expect with a high CCP antibody, even if it's presenting as a more episodic, if you have high CCP antibody and you find a joint that is continuously, episodically, or monoarticularly getting involved as part of rheumatoid, and there's constant inflammation in a certain joint, you would expect to see periarticular osteopenia. And if it's long-standing, you would expect to see the subluxation. Or again, if it's the inflammation staying there for a long period of time, you would expect to see that bite taken out of. So those are hallmark findings for all rheumatoid presentations. But the presentations themselves can come and go. The symptoms can present in 3 different ways.
Thank you. So our last couple of questions are related to your residency experience. So for the first question, why did you choose to pursue a fellowship in rheumatology following your internal medicine fellowship?
My grandpa, he was a radiologist, and he used to go over these images with me, like in his office, and then he developed really deforming chronic arthritis. He was wheelchair bound towards the end of his life, and I don't know, I feel like I wanted to study it more maybe I could have done something, etc., etc. And then came time for med school and biology and everything. Every time I'd go to the rheumatology chapter, I would get excited. And I wasn't sure exactly till the second year of residency. And there was a couple other things I was considering as part what to do my specialization in. So I rotated those through, and I'm like, the first day in rheumatology, I was sure. I was like, this is it.
So speaking of that, so during residency, you're able to, is that when you also can go do more rotations to see where you want to specialize in specifically, and what year of residency would that be?
Yes, in our residency program, they called it electives. And so I finished my residency in 2016. And between 2013 and 2016, first year, I think we had fewer electives, but second year, we got a little bit more elective time. And third year, we had a lot of elective time. So usually residents would know by second year because they would just have a short list of what interests them, just theoretically, and then rotate through those services to see which ones appeal to you, because things may seem like they might be interesting, but when you go through the rotation, you find out this is not for me, or this is a deal breaker. For some, it has to be challenging all the time. Like for me, like I always felt anybody who had a question about whether there was a lack of diagnosis, when people were confused, they would also say, let's get rheumatology. So I don't know, I just felt really good about that. As in attending to every time people were confused or at their wits' end about what is going on, let's call rheumatology. And often, more often than not, we would find what's wrong, and it was autoimmune. But just that feeling of yay, that was amazing. So
That's good to hear. So how do you keep up to date with the latest developments and research in rheumatology? Is there any websites you guys use, or any books specifically that you guys refer to?
Funny you should say up to date, because there's a website called up-to-date.com, and we do use it a lot. It's like our religious text for medicine. It has all the updated guidelines if you are looking for like a quicker answer. And then there's in up-to-date.com, there's all these little links of which exact PubMed publication or paper you should look at. And then you can also look at PubMed to see there's a search bar, and you can type and see which exactly what your question is. Is it about a certain interleukin? Is it about a certain ESR marker? Whatever your question might be, you just type that and you'll find a ton of publications, peer-reviewed articles, lots of things. So both of those are really good.
Thank you. Do you have any advice for us future students, or for any further resources who are interested in learning about pursuing a career in rheumatology?
Shadowing is a great thing. I mean, if future students want to find out if rheumatology is for them, then rotate with the rheumatologist, see if you like the lifestyle, if you like the types of diseases we treat and see on a daily basis. Rheumatology is a primary outpatient subspecialty. So if you don't like hospital rotations that much, or you want a mix of both, it can be a great inpatient to outpatient ratio, because you primarily do outpatient clinic and then you do inpatient rheumatology, which is a completely different. So inpatient, like people admitted to the hospital that need a rheumatologist, are completely different disease presentations. You don't see all that in the clinic. So it's a good mix of both types of spectrum.
Thank you. And then for our last question, how do you manage your work-life balance?
I think it helps to have my specialty. I think it's people in this field particularly do get to control their schedule. What I do is I try to do sign up for stuff that I know I can do my best at. Like I have this thing, if I'm going to sign up for something, I'm going to make sure that I do it really, really well. So I have 3 kids at home, so I do try to cater to their needs to pick and drop after school and whatnot. But then when I'm at my work, I make sure that at my work.
Thank you for that. But thank you guys. Thank you so much, Dr. Shahnawaz, for all. Those are all the questions we have for today. We would like to give you a warm thank you, everybody in the chat box, for this information session. So thank you.
You are most welcome. It was a pleasure talking to all of you. If you think of any questions, just email me and I would be happy to answer anything more if you think of something later. Thanks for having me.
Thank you.
All right, bye.
So now we're just going to conduct our closing session and our future session dates. So this is the quiz slide. So the link is to the quiz for the session is now live. You will need a 70% or higher to pass and receive the certification. I'm going to send the link. The link is in the chat to send for the quiz. And now on to our next session dates. So August is still Rheumatology month. So these will be posted out through our social media outlets, and be sure to follow us at TeleShadowing on all social media platforms. Our next live session will be next Saturday, August 19th at 10 a.m. Eastern Standard Time for another Rheumatology session. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions. And this will conclude this week's shadowing. Thank you so much.